Hello, my name is Marc Hubert. I'm the director of the French Reference Center for Pulmonary Hypertension in Paris at the Université Paris-Saclay in the south of Paris. And I'm really delighted to share some news from PAH research for the European perspective. And many thanks to PHA Europe for kindly inviting me to share this news with you. I have very good relationship with you all, and I know you are doing the best for the patients at the European level. And I would like to congratulate you and be sure of my total support for that. As you can see on my slide, I work also for different institutes, such as INSERM, which is the French National Health Research Council, the Paris hospitals, and you see the three logos here in the middle correspond to the equivalent of the French Pulmonary Hypertension Network and the French Rare Disease Network. So we are very fortunate in France to have a strong support from the Ministry of Health for rare lung disease, including pulmonary hypertension. And of course, and I will discuss that later, European Reference Network is very important, and the ERN Lung is a strong partner for rare lung disease at the European level. So I would like to start my presentation with my disclosures. I have financial relationships for my institute with all the drug companies developing or marketing drugs in the field of pulmonary hypertension. Some of these companies are very small and try to generate new options, new possibilities for treatment of PAH, and I do hope that these companies will develop new possibilities for the treatment of PAH. So, at a European level, we are strongly supported by not only the European Commission, but also the bigger European Society of Cardiology and Respiratory Disease, and we are able to generate guidelines together with European Society of Cardiology and European Respiratory Society. The last update of the guidelines was in 2015, and these have been extremely important. They have really set the scene for a better management of pulmonary hypertension at an international level. And together with Nazareno Gallia and myself, many European colleagues you know very well and who are very strong supporters of PHA Europe have worked together to generate good quality guidance for pulmonary hypertension in Europe. I would like to emphasize the fact that PAH remains, sadly, a severe pulmonary vascular disease characterized by chronic precapillary pulmonary hypertension due to progressive remodeling of the small pulmonary arteries. You see here on the left, you have a small vessel, which is normal, with very thin wall. And you can imagine when the blood flow increases at exercise through these very thin vessels, they can inflate and they are not resistant to blood flow. On the right-hand side, you see what's happening in a patient with PH. The vessel is remodeled, it is stiff, it is very resistant to flow, and the consequence will be that the right heart pump will fail when it will try to generate the reasonable blood flow at rest and exercise. The risk is, of course, death of right heart failure. And we do all we can to treat this very severe condition with the best drugs we can propose to patients. PH is rare. The prevalence is around 15 to 50 per million. It means that in the countries in Europe, around 50 cases of PH are seen per million of people living in our countries. The incidence means the new patients per year, you have around 6 per million per year. So clearly, we have not many patients, but the good thing is that you have done a club. You have put together PHA Europe and other societies in all the countries in Europe. And this allows to have a strong voice. Even though you are not many, you have a good representation at the European level. We understand also very well the pathophysiology of pulmonary arterial hypertension, and the pathophysiology means the mechanisms. And we know that the small vessel have endothelial cells. These cells are the cells which are between the blood flow here in the middle and the tube forming the vessel. And here you see the lining of the tube, it's endothelial cells, and they are able to generate, to produce some hormones, which are called prostacyclin, nitric oxides, endothelin 1. And these mediators are able to talk with the small muscles which surround the vessel, and these muscles will be able to constrict or to proliferate, and this will be abnormal in the setting of PAH. And this abnormal crosstalk between the endothelial cells here and the smooth muscle cells here will lead to pulmonary arterial hypertension. And the beauty of the research is that thanks to the better understanding of these pathways, which are not functional, we have been able to produce drugs thanks to big pharma or small pharma and basic scientists. The endothelin pathway, the nitric oxide pathway, the prostacyclin pathway can be targeted. And this is very good for the management of PH. Even though we are not able yet to cure the disease, we can improve it markedly. I would like to really acknowledge the very strong influence of big names in physiology and medicine who were awarded Nobel Prize for some of them for the discovery of prostacyclin, like John Vane, nitric oxide, like Forsgott, Ignaro, and Murad, and endothelin 1 for Ian Akizawa. All these people have been able to identify abnormal pathways in the vessels, and research has been generated, and this research has been able to produce drugs which have been tested in large randomized control trials, demonstrating the importance of prostacyclin therapy, of NO-directed therapy, and of endothelin 1 directed therapies. But despite all these major improvements in the management of PH, we all share the difficulty that PAH remains a very severe condition with still not satisfactory, unsatisfactory survival. And together we have to work very hard. And we need first to better use the available therapies, and we have also to develop novel therapies. So first, better use currently available therapies. I think we know how to risk stratify the patients, and we know how to combine the drugs as well as possible. So risk stratification has been promoted by the 2015 ESC ERS guidelines. I'm not going to make a difficult talk, but bear in mind that we are able, thanks to clinical evaluation, what the doctors does in the clinic, but also with the exercise test, 6-minute walk distance or CPET, or biomarkers of right heart function, either in the blood with BNP or with echo or with right heart catheterization. We have been able to generate a risk stratification instrument, a risk stratification tool, which has been properly studied in Scandinavia, in Sweden, in Europe, in Germany and other countries, and in France. And all these risk stratification exercises have validated the ESC-ERS risk stratification approach. And we know now how to determine uh, treatment goals and future risk in patients with PH. And we can better use treatments thanks to these risk stratification assistance. We also know how to combine treatments, and more we combine treatments upfront. This is a very simple cartoon on which I show what was the traditional combination therapy approach, where we started with one drug, and when the treatment goals were not met, we were combining with a second one, then a third one. Upfront combination allows initial combination of two and sometimes three drugs in the most severe patients. So this is an evolving paradigm, and there are important articles published in the New England Journal of Medicine, which were event driven and which clearly showed that when you combine an ERA, endothelin receptor antagonist, and a PD5 inhibitor uh, upfront, you have better time to clinical failure as compared to initial monotherapy. Of course, we need to work and try to find new options, but in the most recent proposed treatment algorithm for PAH, proposed at the Sixth World Symposium of Pulmonary Hypertension in Nice in 2018, we have been able to show that in patients who are non-vasoreactive, we do estimate the risk. You see here intermediate or low risk, and in those patients, we usually propose initial combination therapy or sometimes monotherapy. And in the high risk, we propose initial combination therapy with a prostacyclin. And as you can see on this busy figure, each time we see the patients, each time we see you or your friend or husband or wife, we do risk stratify in order to see what should be the next option. Should we maintain the treatment, or should we add a new treatment on top of what we had? So this is really nice, and we are lucky to have these new assistant tool to help us provide the best management to patients. Of course, you know, I'm a researcher, I'm a clinical translational researcher. I have one step in the clinic, one step in the lab, and we try to develop new therapies. Institutes and pharma develop novel drugs targeting the three pathways. We have seen that recently, and this is very useful. But we have also new treatments in development targeting other pathways. We try to find a fourth pathway, a fifth pathway, and maybe a treatment which can reverse the disease. So we try to target new molecules like the growth factor PDGF. We try to rebalance the genetic defect which have been found in patients with familial disease like the gene BMPR2. We try also to rebalance the abnormal TGF beta receptors with new treatments trapping molecules which are binding the TGF beta receptors. And we are also developing new options around serotonin and other pathways. So that's really important. And we also try to develop new technologies to try to generate better assistance to the patient and treating physicians. So we have a very strong research and translational research. We have a lot of novel targets. And the major challenge is to prioritize drug discovery and development for PAH. And you see here on this very simple cartoon derived from articles we have published in recent years, we have lots of ideas: inflammation, growth factors, BMPR2, TGF beta, um, so inflammation, growth factors, BMPR2, TGF beta, calcium signaling, vasoactive peptides, neurohormonal activation matrix, angiogenesis, and mitochondrial metabolism. And the big thing we have to do is prioritizing. And right now, my feeling is that the most promising targets certainly will be derived from a better understanding of the remodeling. And currently, what is around BMPR2, TGF beta signaling and growth factors is certainly the uh, drug priorities we are currently discussing in the pulmonary hypertension centers right now. You will see very soon new articles from phase 2 trials, which are quite promising. But of course, phase 2 do not mean that we have already the solution and a new drug in the clinic. But in the partnership we have together, we can share with you what are the most promising ideas which are in the air. And clearly, next time we meet in person, I hope we will be able to have debate and discussion around these lines. So now I would like to discuss the unmet needs for research and development, how to do better together. We all know that financial support has to be increased, so we are well identified at a national level, at a European level, at an international level. So we need more support for you, for us to develop new concepts and new ideas. Clearly, the multi-center networks in strong association with industry and patient association with multidisciplinary teams will be the solution for better delivering of new options to patients. So at a national level, for example, my French National Reference Center on pulmonary hypertension is well supported by the French Ministry of Health. I hope it is the same thing in all the countries. I know it is challenging in some countries. At the European level, the European projects, the Horizon 2020 project and the New Horizon projects, and of course, the European Reference Network for Rare Lung Diseases with the core network on pulmonary hypertension I chair is really the way to go. And there is a key role for medical societies like ESC or ERS, and also the patients association like PHA Europe and European Lung Foundation for the respiratory diseases. And I know they are good partners for you. A very brief presentation of what we have built in France. We have a strong university. The name is not yet very famous, Université Paris-Saclay, but it is the first university in the Shanghai rating in the continental Europe. If you include, of course, the UK in Europe, and it should be included, you have Cambridge, Oxford in front of us, but Paris-Saclay is the third. So this university, which is strong in mathematics, technology, and medicine, has identified pulmonary hypertension as a key priority. And you see, this is Paris. We are in the south of Paris, so this is a ring circle around Paris. And my reference center is here. The surgical center is here. The basic science campus is here. The Cancer Institute is here. So we have a lot of networking hanging around and a strong faculty of medicine, faculty of pharmacy, faculty of sciences. So this is a good field to develop translational research. And upon the strong rare disease priorities built by the French Ministry of Health, we have been asked to identify and support a network of pulmonary vascular centers in France. So Paris is here, north middle, and we have in Paris other colleagues. And outside Paris, we have included 25 what we call competence referral centers, which are in each region of France. And we have two centers overseas because you remember France has a strong history of overseas relationships. So we have one in the Caribbean and one in the Indian Ocean. And with this network of centers throughout the country, we have also a research department in the Université Paris-Saclay, supported by INSERM, and we have a strong basic research field, we have a strong clinical research field, and there is a dialogue, there is a crosstalk for discovery and validation between the two. And around that, we have experimental model for surgery, we have a tissue bank for patients who have been transplanted, we have biobank, we have genetic research and counseling, and we have the French National Registry. So this is really a good, strong support for research in pulmonary hypertension. But of course, you wanted to hear about Europe. And my institute is, of course, very influential and very committed to a better care at a European level. And here, the European Reference Network for Lung Disease is really important. And you know the mission of ERN Lung, it's a network of European healthcare providers dedicated to ensuring and promoting excellence in care and research to the benefit of patients affected by rare respiratory diseases. It has been approved in 2017, and the vision was to be a European knowledge hub for rare respiratory diseases. Of course, in 3 to 4 years, it's too short to generate what we have done in France. In France, we have been approved in 2004, so nearly 17 years now. The objectives was to use the expertise at the European level to assess the gaps and identify solutions, to improve cross-border collaborations, and indeed the COVID situation has made a virtual meeting a must in that area. We need to advance innovation in medical science, reinforce research, epidemiology, improve training, improve clinical trials, improve registries. Ensure access to quality and accurate information on rare respiratory diseases, and strengthen the skills, competencies, and abilities of target groups. So we have members, and among the members, we have supporting partners, we have the patient association, and PHA Europe is important in the core network on pulmonary hypertension. And we have external audiences. ERN on rare respiratory diseases, so ERN Lung, had 60 centers from 12 countries organized across 9 functional committees. And what is really important for you today is to see that pulmonary hypertension was in the first line, one of the first priority. And I was very happy to be in charge of pulmonary hypertension at the ERN level. You see cystic fibrosis, you see interstitial lung disease, so very important diseases. And we are part of the priorities. We are a core network. But of course, the financial support is not strong enough, and we need to build together something more influential. The functional committees are important, and you will see that there are some which are really important for you. Patient-reported outcomes and quality of life, research and clinical trial, ethical issues, registries and biobanks, guidelines and best practice of care, cross-border care, training, and CME. So we have a lot to do together, and I'm very happy to work with you, with all the people I'm very happy to meet, like Gergely, like Halskara, etc. The role of the core networks and the functional committees, it's a bit different, of course. The core networks, it's responsible for the development of specific plans for the disease and to provide input and implement the activities for the disease. The functional committees are more translational and multidisciplinary. So it is the interoperability of all the core networks together. When we discuss, for example, registries, it's not only pulmonary hypertension, it's pulmonary hypertension, primary ciliary dyskinesia, cystic fibrosis, interstitial lung disease, etc. So we have a lot to do. So for pulmonary hypertension, when we started, so I was the lead representative here in Paris. We had the deputy representative here in Bologna. We had the patient representative here in Hungary. And we have a lot of centers throughout Europe, but not everywhere. And you know that sadly we had the Brexit, but we have been able to maintain the contact and to offer our British colleagues a partnership which is identical to what we used to have. But you see that in the eastern part of Europe, we have a lot to do. And certainly in most recent years, we have been able to propose new names, and the European Commission is going to validate or not these new names, for example, in Romania, etc. So we have a lot to do, and we hope we will do it together. So when we meet, and when we used to meet in person, we had nice meetings. And I just wanted to share with you the most recent face-to-face meeting we could do before COVID. So we had an ER and lung update and an update on the cross-border care with a clinical patient medical sharing information, so a clinical platform. And Thomas Wagner is the lead of the not the PH, but the ER and lung. So he gave us some information and all the difficulties he has to face. Kirtana Iyer works with me in Paris, full-time for ER and lung. She's a Indian-born, British-raised, French living, oriented to Brussels person, very, very nice, and I would like to thank her warmly. Then we had a discussion on the registry with my colleague Olivier Sidbon. We had a discussion on the relationship with European Respiratory Society. And as you may know, I will be the next president of the European Respiratory Society in September 2021. So the next year I will be the president, and I would like rare disease to be my main task. So you can count on me, and I would like you to interfere with me as best as possible in order to have strong relationship. You know already that we have a task force on CTEPH, and we have published this in December last year. We have a clinical research collaboration on pulmonary hypertension with Olivier Sidbon and Abilio Reis. It's called PHAROS, and we have also Horst Olszewski and Gabor Kovacs in Austria working on PET-NEX, on exercise pulmonary hypertension. Marion Delcroix, Céline Janton from ERS are very important. We are doing new guidelines, so I'm not supposed to share anything about it except that it is up and running with patient representation, and it is chaired by ESC and ERS with a good rhythm and a good production. We have a very close relationship with you guys, and Gergely regularly comes to our meetings, and I'm sure that other people come, and you are most welcome to have not only links with us, but also with the European Lung Foundation. Some data on the pulmonary hypertension core network. So we try to do what we call a warehouse of registries at the ERN level. It's very technical. It's not really interesting for direct patient information, but PHAROS is more interesting. So PHAROS, it is the pulmonary hypertension registries supported by the European Respiratory Society with Olivier Sidbon and Abilio Reis. We try to have a severe pulmonary hypertension management information across Europe. We try to see how patients deal with the most severe cases. We try to have a platform for clinical research in pulmonary hypertension. We try to provide expert opinion. We try to prioritize clinical network um, for clinical trials. So we try to say this is a priority, this is less a priority. We try to have very good patient access across Europe, and we thank Adam Torbicki from Poland to be very aware of the difficulties for patients coming from more remote places in the east part of Europe sometimes, but also in countries like the main countries when you live in more remote areas. We try to see the most severe patient characteristics and see if we can offer better care. The phenotype and treatment of patients with PH due to lung disease is also very important. So I've already mentioned the relationship with European Respiratory Society. I've already insisted that we have to deliver guidance together, and my role as future European Respiratory Society president will be to have you with us close together for the best of patient care. The guidelines will be published in a year and a half, both in the European Respiratory Journal and European Heart Journal. And the European Respiratory Society Assembly 13 is entirely devoted to pulmonary vascular disease. It is currently chaired by my friend and colleague Marion Delcroix from Leuven in Belgium. The secretary is Anton von Nodegraaff. We have a group on pulmonary hypertension. We have a group on right ventricle, and this is really important. New elections have been done. There will be new chairs and new secretaries in September 2021, and we will focus more our attention on pulmonary hypertension, and this will be a very important task. So we know all the publications. We have published the proceedings of the Sixth World Symposium. We have published the ERS Task Force on chronic thromboembolic pulmonary hypertension. We will update the pulmonary hypertension guidelines. We will have European Society of Cardiology and European Respiratory Society meetings. For the ERS, it will be hybrid, so we will be able to travel in September 2021 in Barcelona. For the patients, it can be a little more challenging, but I would really like you to be with us closely, at least virtually, but you can count on me to be close to you for the next year, and I really like interfering with you. My final slide is to emphasize again this European Respiratory Society clinical research collaboration on severe pulmonary hypertension management across Europe. It is strongly supported by ERS Assembly 13. You are welcome in this exercise. You are also welcome in the PH guidelines and in the CTEF guidance. And I really hope to work every day with you. I wish the best to the Pulmonary Hypertension Association Europe, and I wish you a very nice meeting and the best for the new year. Thank you very much.